Arizona.
Almost
And
forgot.
that, no problem. And it's been over a decade since I've completed that 2-year fellowship. And once you go down the path of integrative and functional medicine, you never go backwards. You only go forwards and keep learning, from everyone that you can learn from, which is like all of you and lots of people. So my area of expertise is, like I said, in women's health, and throughout a woman's adult lifehood, there's always a role for hormones. And so poor hormones, I'm always having to defend them, because we know that after the Women's Health Initiative, which is from 20 years ago now, women's hormones were looked at as evil for them. And so I try to educate and get people on board with the role of hormones and how we can use them effectively and efficaciously to help women as they go through all the stages of life, to balance them when they're younger and then supplement them when they're older. And then, of course, nothing lives in a vacuum. So you can't just give hormones. You have to do everything to deal with all the lifestyle issues that we all deal with. So that's basically my background. And in terms of my topic for today, I thought I would talk about hormones and brain function, and we can kind of do an overview of that. So I'll bring up my slide deck here. And
okay, we see it.
Oh, good. So let me see, where is my slide? You select presentation. Okay, I'll put this up here. It's a bit out of the way. So we're going to talk about a big topic for women's health, which is about healthy brain aging. And I'm sure you've dealt with that many times over, but I can't emphasize how life is not quite what it should be if your brain isn't working well. It's kind of one of the prerequisites to having a quality life. And women do have more issues with their brains, and a little different issues than men. So I always talk about the differences between men and women. They're quite substantial. So we're going to just talk about the connection of hormones and the importance that they play. And then, of course, a little something about how to deal with the implications of aging, which I know you know about, but we're going to go over my approach. So when we look at this slide, and it's looking at so many different things that can impact brain health, you're looking at the GI tract, which is such an important topic. You're looking at the environment and diseases and so on. But notice I keep looking at, I see this everywhere I go, slides and talks that talk about so many different things, but they never talk about hormones, because it's like the forgotten component. So we're going to bring hormones back into the conversation. But I know for you guys, this isn't exactly a novel idea, but cardiologists, gastroenterologists, you can go through many subspecialties, and they don't ever think about hormones. I talk to my patients who go to them and they never bring up the topic of hormones. And that includes the vast majority of neurologists as well, and psychiatrists. It's like, how come they don't think about that? Well, of course, a lot of them don't think about food either. So what can we say? So it's so important to have physiologic levels, not just what came out in the Women's Health Initiative, which was, if you're going to use estrogen, you give the smallest possible dose for the shortest amount of time. So my analogy with that would be, would you ever say that about vegetables? Like, well, you should give the smallest amount that you can survive with, like 1 bite a week. I mean, that doesn't make any sense. What we do in everything is we want to give the most efficacious, which means physiologic level. So you look at, when is a woman really at her peak health? And generally it's like in her 20s. So those are kind of the levels that we would be looking for. I know doctors who replenish hormones, but they try to give them to the level of someone who's 60. I don't think that's the goal. We're going to go for for the gold here, which is getting a proper level that is, aligned with optimal health. So, and the brain, of course, is no different from any other organ in that for it to function optimally, it has to have all of these hormones. Now, normally I talk predominantly about estrogen, and the one that I always talk about the most is estradiol, but I'm going to bring in all the hormones, and I do not want to look like I'm always discriminating against the other hormones just because estrogen's my favorite, because you really need the total blend. It's really like you're trying to make an amazing recipe, a dish. Well, you may have one main ingredient, but you need to have all the others for it to actually taste very good. Like if you've ever watched some of those like food challenge TV shows, I don't know, do you ever watch any of those things? They're kind of fun. Sometimes they say, here's your like main ingredient. You have to make this ingredient the star of this dish. Well, that is the star of the dish, but you can't make the dish if you don't put a bunch of other ingredients in. So that's how all the other hormones. I look at estrogen as the sort of like the pinnacle star, but the others are essential players. You can't have a show if you don't have the supporting characters. So sex hormones have always been looked at as sex hormones. So I don't like to use that expression because it's not about just reproduction, not at all. And that's because no one can be fertile if they're not healthy. So nature made it so that hormones are present in receptors, throughout the entire body. So it's not just about sex. So I changed the name. I officially changed the name, and you can adopt my name. They're not sex hormones, they're life hormones. They're truly about sustaining life. So if you look at the hormone receptors, they're of course in every single tissue. That's because the prime directive of life is the creation of new life. I figured that out a long time ago as an obstetrician. In the first 25 years of my career, I delivered thousands and thousands of babies, lots of high-risk pregnancies. And it was pretty darn obvious that the prime directive of life is the creation of new life, and that humans are the only species that actually tries to control reproductive destiny. I mean, you put any other animals together and they breed. That's just how it goes. That's what nature intended. Only humans try to have sex without breeding. And so we are unique among all planets on this, of all animals on this planet. And so I'm totally for controlling when you have kids. I don't want to make it sound like women should be breeding factories, not at all, but we should recognize what the body is designed for. And then we can do whatever we like as far as how to control it. And that's a whole nother topic, hormonal contraceptives, which unfortunately are not health hormones. They're all non-human hormones. They're all actually endocrine disruptors. But that aside, I don't want women to have babies when they're not interested in it. But we do need to understand that the female body is designed for reproduction. And to be successful in reproduction, you have to have proper organ functioning. Like you need to have a really stellar heart and a great brain, and you need to have a good gastrointestinal tract. You need to have everything working well. A lot of people don't realize, and we can talk another day about the heart and the whole cardiovascular system, but pregnancy is a stress test for women. It's really important to know that, and that the hormones of pregnancy are not the hormones that exist at any other time in a female's existence, except during pregnancy. And pregnancy is actually a pro-inflammatory state designed to make women a little bit insulin resistant so that their glucose levels go up, their insulin levels go up, so that they put on more body fat quicker, and that the babies also get bigger quicker. So we don't really want to replicate the hormones of pregnancy when women are not pregnant. And so that's like just an important takeaway. But when you look at the heart, for example, the heart of a female has way more mitochondria than a male heart, because during pregnancy, the blood volume doubles. So the heart of a female has to pump twice as much blood around when they're pregnant. So the heart is different. And the brain has differences too. And we've learned so much more about the brain and the lymphatic system and the immune cells. And all of these are in many ways related to hormones. And so we need to just be aware that the whole body of a female has hormone receptors in all the different organs. It's all designed to keep all the organs working in beautiful synchrony for the purpose of successful reproduction. And the brain is no different. So we need to know that all of these hormones are life hormones designed to support life throughout the whole body, not just sexual organs. And so estrogen is misunderstood. And in fact, if you know the Women's Health Initiative, they actually came out and said that estrogen increases dementia. Do you remember that? And of course, what were they using? They were using the conjugated equine estrogens combined with the medroxyprogesterone acetate. So these are not human hormones. And when you are giving Premarin, that's the brand name for the conjugated equine estrogens, it goes into the body as estrone, not estradiol. And it's very different in the brain because the brain loves estradiol. It does not love estrone. Estrone works predominantly on the alpha receptor, but not on the beta receptor. And estrogen has 3 main types of receptors. There's actually more, and the membrane receptors, jeepers, are more complex than just one. And the ones that are considered nuclear receptors, alpha and beta, turns out they're more complicated and they're also membrane receptors. But the brain has the array of receptors, but estrone is only alpha. And the brain doesn't love estrone and doesn't even produce estrone. The brain makes estradiol for a balanced effect throughout the brain. So this is really important, that estrogen is neuroprotective, not like the Women's Health Initiative came out and said it causes dementia. Now, how can it be harmful? Well, in estrone coming orally, it turns out that Premarin increases the risk of blood clotting 400%. That's over baseline. That's huge. So if you have elderly, unhealthy women with vascular disease, which is the group that they actually tested in the Women's Health Initiative, you will be more prone to blood clots. That's why we don't give, not that I like them ever, but we certainly don't give birth control pills to 58-year-old women or smoking women or women who just had a heart attack. We wouldn't do that because it increases blood clotting, platelet aggregation and blood clotting. It's pro-inflammatory because blood clotting is actually part of the inflammatory response. And so that is a clue right there. Estrone is pro-inflammatory. Now, estrogen in the form of estradiol actually has a balanced effect on the immune system. It actually is an initiator of the inflammatory response. It also is the initiator of the anti-inflammatory response to then create healing and resolution of the inflammatory response, which is one reason why women who have estrogen on board and women who have estrogen naturally made do better in infections than do men. That they have like a 60 to 40% differential in, for example, survival from COVID cases, or you can pick brain trauma, all kinds of sepsis and so on. Premenopausal women have a much higher survival rate from sepsis as do men. Estrogen in the form of estradiol is very, very important for the immune response. And of course, the brain is no exception. But when you don't have the right form of estrogen, like you have estrone coming from Premarin, which only works on the alpha. Now, it turns out that the innate immune cells, like the macrophages, the neutrophils, the mast cells, they are all alpha receptors, predominantly alpha. So when you only have estrone, which is, and by the way, birth control pills go into the body predominantly as estrone, which is why they're procoagulants, you end up in a state of activating the inflammatory response system and the innate immune cells, but not in a regulated form, because without activating the beta receptor, you don't get the resolution phase of inflammation. You only get the activation phase, which is not what anyone wants anywhere, especially in their arteries and certainly not in their brains. So we need to just rethink and recognize that estrogen, and I write estrogen, but most of the time I'm referring to estradiol, but estrogen is a family of hormones. It's not a hormone. And it comes in different flavors, like estriol, the dominant estrogen of pregnancy, estradiol, the dominant estrogen of reproductive years, and estrone, which comes from things like Premarin and birth control pills, and is the dominant estrogen in the menopausal years, that is made in inflammatory fat tissue by the activation of the conversion enzyme aromatase that converts the androgens that come from predominantly the adrenal gland into estrone. And so estrone works predominantly on the alpha receptor, which is more the pro-inflammatory process. And that's what gave poor estrogen, but all estrogens, including estradiol, a bad rap. So remember, everything about life is about survival and reproduction. So here in this slide, it just shows that the dominant types of receptors, and we keep learning more, is the alpha and the beta and the membrane receptors. And they do cross-talking with one another. They're not like working in a vacuum. And it turns out that when you have beta, high beta agonist effects, so the beta receptor is being very activated, it actually downregulates the alpha receptor, which is very important in pregnancy because estriol is predominantly a beta receptor agonist. It binds to the beta receptor, which downregulates the alpha, which is why in pregnancy, the innate immune system is less competent. And that's why pregnant women get more infection outcomes that are bad, like from the flu or chicken pox, things of that sort. So they have more bad outcomes from infections because their innate immune cells are actually downregulated by estriol. And it also turns out that this is a bit of a benefit if you have certain autoimmune diseases, because it also downregulates the innate immune cells that are making the inflammatory cytokines. So for example, women who have multiple sclerosis will often have remission in pregnancy, but it comes back later because it's basically an immune modulator. Okay, so we have to think twice about giving this to postmenopausal women because you're down-regulating the innate immune cells, potentially putting your postmenopausal women at increased risk for bad outcomes from infections. And plus, we don't think that alpha is bad. It's all about balance because in the brain, the alpha receptors are predominantly in the hypothalamus, the hippocampus. So it regulates memory, and it also regulates the appetite, and that's really important. So a lot of metabolic effects are through the hypothalamus. The master clock, the suprachiasmatic nucleus, is in the hypothalamus that regulates the circadian rhythm, and that you need alpha for. Now, the cerebral cortex is predominantly beta, and so that's a lot about, how your cerebral cortex is working, but you need both. You don't want just alpha, you don't want just beta, and only estradiol gives you the balanced effect, which is really important for the brain. So that's one of the reasons why sometimes women talk about baby brain when they're pregnant, or the pregnancy brain, because they're down regulating the alpha, and they're, also only predominantly beta when you have so much estriol. And so the hypothalamus and the hippocampus, where you're talking about memory, is going to be less functional. So, and we don't want that after menopause either. So pregnancy is a very unique state. We don't want to replicate the hormones of pregnancy in women who are not pregnant. And we need to just realize that the brain has different concentrations or predominance of different types of receptors. And the membrane receptors are throughout. And the brain itself has its own type of immune cells, the microglia. They're modified macrophages, and they are predominantly regulated by alpha. And when you don't have proper balance and you have too much alpha, like too much estrone, not enough of the beta after menopause, when estrone becomes the dominant estrogen, you get an upregulation of the microglia, and they become like weapons of mass destruction in the brain, putting out their dissolving enzymes, like matrix metalloproteinases, all of these dissolving enzymes, myeloperoxidase, lipoprotein lipases, dissolving type enzymes that are designed to dissolve damaged tissue or pathogens, and they'll start dissolving our own healthy neurons. So this is why we definitely need that balanced effect of estrogen in the brain. And that's just showing that you get a protein, you get a physiologic response. Of course, hormones have to bind to their receptors. So in the brain, estradiol increases neurogenesis in the hippocampus, where you have memory creation, neurogenesis, creation of new neurons, and it helps tremendously with memory. Almost all women, as they're transitioning into menopause, have problems with their memory, particularly retrieval of nouns. And this has been shown, it's pretty universal that they have noun retrieval problems. I can't remember names. So they can describe things. So women, we're very good with adjectives and verbs, but not so good with names. So we say remember that person, and then you could describe them, but you just cannot remember the name, or the name of a movie, or the name of a place, a city where you went on a vacation. So you can describe it, and you can play charades and so on, bigger than a bread box, smaller than this, it had a color, but you can't remember the name. So that's all modulated through estradiol. And estrone has actually been shown to cause decreased survival of neurons and does not activate the production of new neurons. And this is really a big deal. So that's why poor estrogen, like I said, when they give Premarin, it doesn't make the brain better, because it's the wrong type. And estrogen, and I use estrogen because most people think of just estrogen, but I want you guys to know, because you're healthcare experts, that estrogen is not a hormone. And that when you talk about proper brain function, we're talking about estradiol. Now, the brain loves to have a lot of estradiol present. So it's actually a paracrine organ. Now, all of you guys out there, you should love estradiol as much as I do, because your brains are filled with estradiol, doing everything that all the things it should do to maintain the health of the neurons, to regulate the immune system, to maintain health of the vascular system of the brain. Vascular dementia is not exactly a rarity. Well, estrogen has receptors throughout the endothelium of arteries, the muscle of arteries, and it helps to increase the production of nitric oxide through action on the enzyme endothelial nitric oxide synthase. So it helps to keep vascular function optimal, so you don't get vascular dementia, and we don't want to get strokes. By the time a woman hits 65, as a general rule for women have more strokes and more ruptured brain aneurysms than do men. So this is a huge issue for women. We don't want to forget about the importance of vascular function. And remember, after menopause, the dominant estrogen made in inflammatory adipose tissue when you have inflammation, it upregulates the enzyme aromatase that converts androgens to estrogens. And that's not an accident. It's because, as I mentioned, estrogen, but in the form of estradiol, modulates the inflammatory response. It initiates it when it's necessary, like if you have an invading pathogen or you have trauma. Remember, what initiates the immune cells to activate? The DAMPs and the PAMPs, damage and pathogens. And all of that is regulated or modulated by estradiol. Remember, every immune cell in the body has estrogen receptors. So it's so important that you have the right amount of estrogen and the right type, estradiol, to modulate the immune system properly. Now, so you want to turn on inflammation when you need it, and you want to turn it off when you don't need it. Now, the reason that men have so much estradiol in the brain is that estradiol, 100% of all estradiol comes from one other hormone, testosterone. So every estradiol molecule was made from testosterone. Now, in the ovaries of women, the enzyme aromatase is there, and it converts the testosterone it gets moved over into the granulosa cells where the enzyme aromatase lives, and it makes it into estradiol. Well, the brain has the same capability. Now, men, you have all that testosterone, or you should, right? This is why men love testosterone and they need it at every stage of life. And people don't realize how important testosterone, I mean, you guys do, but most lay people, they don't understand how testosterone is so critical to the brain. Now, men make the vast majority of their estradiol in their brain from their testosterone. The brain has the enzyme aromatase everywhere to convert testosterone into estradiol. During the reproductive years, men make 6 to 8 times more estradiol in their brains than women do. But it's okay because women get estradiol, assuming they have functioning ovaries, and they're not on estrone like birth control pills. They make their estrogen, their estradiol in their ovaries, and it circulates and it enters into the brain. So women have plenty of estradiol in their brain during the reproductive years. But after menopause, how much testosterone does a woman have? Not that much. So they can't make the estradiol conversion into testosterone to enable the brain to work optimally. So this is a very big deal because loss of estradiol in the brain means losing the support of the neurons and the immune system and the vascular system in the brain. So women, compared to men, have an incidence of Alzheimer's disease over 2 times, like 2.5 times the incidence of Alzheimer's. So women tend to statistically live a little bit longer than men, but not well, because they have so much more Alzheimer's disease. They have more strokes. They have more, 80% of osteoporotic fractures are women, and they have more joint replacements than men. Talk about pain. Women have substantially more pain than men. In fact, if you go to a dispensary, who is there typically in a dispensary? Young males looking for recreational marijuana and old women looking for medicinal marijuana because they're trying to self-treat for all their symptoms that they're not being addressed by their doctors. So, I mean, this is a fact that these are the most frequent people in a dispensary, So, poor women talk about cognitive function, it links with mood. That's why I have cognition and mood. They go together. Like people with Alzheimer's are always having crazy mood instabilities. And of course, sleep, all of these things are brain functions. The brain doesn't segregate mood from cognition. Women after menopause, statistically, if they have no history of prior mood problems, no history of anxiety, no history of depression. Once they transition into the menopause, their incidence of anxiety and mood disorders, depression, doubles, 200% increase. And what about women who have a prior history of like bad PMS, postpartum depression? Their incidence after menopause goes up 400%. This is terrible. That's because estrogen in the form of estradiol is a life hormone to the brain. Forget the sex part. Nobody cares about having babies when you're 70, but we sure care about having proper brain function. And how about mood? So now I pretty much never tell anyone this, but just between us, what stays in our little room here. Part of the reason I'm so passionate about this whole thing is that my paternal grandmother committed suicide when she was going through early menopause. She had the worst hot flashes and mood problems. There was no treatment, and she jumped out a window from an apartment building in New York, and I'm named after her. So this is not theoretical to me. This is what happens to women. Now, not everyone jumps out a window, but we have treatments for this now. And the treatment is predominantly a combination of lifestyle and hormone therapy, none of which were available to her back a long time ago before I was born. So this is a really big deal. Women's quality of life is not optional. It has to be a priority, and it isn't in our conventional medical world. So this is how the brain gets estradiol. It gets it by converting testosterone into estradiol, but it can't do it very well in women because there just isn't that much testosterone to work from. By the way, there are some people out there who, for whatever their reasoning, they're giving massive doses of testosterone to women. You've seen that, where they're giving massive amounts of testosterone. So they're getting levels up well into the 300 and 400 levels, like male levels, with this concept that if you give women a ton of testosterone, somehow they'll convert it to estradiol appropriately. But that isn't how it works. That's how we do transgendering, by the way. That's not what we're looking for. So don't do that, you guys. Don't give women huge amounts of testosterone. Their enzyme aromatase wasn't designed to convert massive amounts of testosterone. We're different. We're not men. So stop doing that. Give them what they're supposed to have, estradiol. And estradiol does cross the blood-brain barrier, of course. So there's been a lot of talk about the timing hypothesis. So I can tell you, and you probably have been aware of this, that Dale Bredesen and his reversal of Alzheimer's program does not deal with timing at all. They say, if you're a woman and you have cognitive deficits, cognitive decline, go on his lifestyle program, which is essentially functional medicine 101, right? He didn't invent it, he just applied it. And every one of his women patients gets estradiol, not estrone, not estriol. They get estradiol. And I was really proud of him for doing that, because he's a neurologist and never learned anything about hormones, because they don't teach him about hormones. Years and years ago, I was at a conference, and they had, this was before the Women's Health Initiative, they had 2 test tubes, and they showed the pictures of cultured neurons in test tubes. And in one, they had a solution that had estradiol, and in the other one, it had the same nutrients, but no estradiol. The neurons that were growing in the estradiol medium looked like a lush rainforest. The ones that were growing in the without estradiol, but they had the other nutrients, looked like a bunch of dead branches. And that picture never left me. And I thought, let's see, which brain do I want? The lush rainforest or the dead branches? That did it for, it's basic science at its best. How do neurons grow? They need estradiol. So now there's so much that goes on with estradiol that goes beyond neurogenesis and beyond the immune cells, because mitochondria require estradiol to work properly. And what organs need the most energy? The heart, and the brain. So without proper mitochondrial function, nothing's going to work right? And some people talk about aging as mitochondrial decline. Well, estradiol works everywhere in mitochondria. So in the electron transport chain, and it's estradiol that modulates manganese superoxide dismutase. That's an enzyme that helps to convert the metabolite that is very toxic in mitochondria, that is formed from oxidative phosphorylation, and it's superoxide, two oxygens together. That's really, really toxic. And this enzyme, superoxide dismutase, converts the superoxide into hydrogen peroxide, which is not exactly healthful. It's a poison, but in mitochondria, superoxide cannot diffuse out of the mitochondria. It stays in it. And if it doesn't get converted and get out of there, it will poison the mitochondria and kill it. When it turns into hydrogen peroxide via that enzyme, it can diffuse out of the mitochondria, where elsewhere it's converted by other enzymatic activity into harmless water that can be excreted from the body. So without proper estradiol, you end up with toxic, situations for the mitochondria, and you end up having this massive energy deficiency in the brain. Now, we see this in women in their heart, which cardiologists always ignore. If you do an echocardiogram on a woman who is losing mitochondrial function in her heart, you can see it as mild diastolic dysfunction. That's an energy deficient heart. And it's a stiffer heart. It doesn't relax well. This is unique to women. Men don't have this problem, and it's just ignored. And the cardiologists say, oh, that's natural for a woman. Well, it may be natural, just like dementia is natural, but that's not what we want. So if you want to find out if your patient's brain is getting estrogen deficient, check her heart, because those are the two organs that need tremendous amounts of energy. Women have more mitochondria in their heart than men because they have to pump so hard, the blood, the increased blood volume when they're pregnant. And so check their heart, and then you'll know what's going on with their mitochondria. If you see mild diastolic dysfunction, and make sure the echocardiogram is read to describe that finding or not, you'll know. So we know that estrogen is essential for neuroplasticity. So in other words, you create more synapses, you have more flexibility in the brain, you increase neurogenesis, the actual creation of more neurons that help with improved learning and memory. It increases the dendritic spine number, so you have better connection between the different neurons all throughout the brain. So this is so important, and it maintains the health of the brain, so you don't have the shrinking brain. Have you seen that, where people get a CT scan of the brain and they say cortical atrophy? Like, okay, they say, well, that's normal. It's like, I don't want my brain to do that. I don't know about you. I don't think so. So we do not want atrophy of our brain. So estradiol helps to prevent that. It helps maintain proper brain metabolism by maintaining mitochondrial function. And remember, the microglia, the specialized neurons in the brain, to have them function properly so they don't become like weapons of mass destruction. And estrogen is a growth hormone. So it has many, many functions. But one of them is growth. Now, you could say growing, I don't want grown people to be growing. Well, growth is healing. Growth is renewal. When cells die, you need growth to grow new cells. If you have trauma, you need to grow new blood vessels, new tissue. Well, all of that requires activation of growth factors. Now, that's actually part of the resolution phase of inflammation. Inflammation is not just about creating, inflammation. It's about resolving inflammation. It's a process. And remember, estradiol works to maintain the entire spectrum of the inflammatory process, which includes resolution. That means damaged tissue that's damaged by a pathogen, that's damaged by trauma, needs to be healed. And those growth factors are regulated by estradiol. So brain-derived neurotrophic factor, which we all want lots of, right? To have brain renewal, regeneration, is activated along with the receptor by estradiol. So when you have like skin also makes estradiol. That's how men have a ton of estradiol in their skin. And that's what promotes healing. That's why old people, when they have trauma to their skin, it doesn't heal well. It heals slower because estrogen creates the healing process. And that requires, all of these growth factors. And so when you think about estrogen, think about renewal, growth, healing, nurturing. So I call it the mother hormone. It's like the hormone that looks out for you to make sure that you are safe and sound. And what about glucose? Well, glucose is the preferred energy source for the brain, not ketones and fat, no. But the brain can utilize just about, anything for energy. It's capable because the brain is so important, but its preferred source of energy is glucose. But that's why they give people who have dementia, they give them ketones, right? Because ketones can cross into the brain without glucose transporter function. Well, it turns out that when you have dementia, you have a decline in brain glucose utilization. And a lot of that is related to not having adequate glucose transporters. And that is like a major deal because we need to get the glucose into the brain. That requires estradiol. That is why virtually all women after menopause become to some degree insulin resistant and develop high rates of prediabetes and diabetes because glucose transporters are regulated by estradiol, the GLUT1, 3, and 4. And the 4 is the dominant one that gets glucose transported into the brain. And without proper glucose, nothing is going to work right. Okay, you can name any organ system. So estradiol helps to maintain proper glucose transporter system. Now, estrogen, as I mentioned, is made in the brain, but in order for it to be made, you have to have the ability, the enzyme, and then you have to have the precursor. So it can be made from testosterone. It can also be made from cholesterol, starting from scratch. That's why when you give drugs that lower cholesterol, you run the risk of inducing some degree of dementia because some of the estradiol comes from cholesterol that's in the brain, ultimately converted into testosterone, which is ultimately converted into estradiol, which of course is all about energy. And I already mentioned this, so I don't have to go over this again, but it's so important to know that estradiol is critically important for mitochondrial function. And what about some of the neurotransmitters? It turns out that estradiol is critical for neurotransmitter production, like acetylcholine, which is when they give drugs like Aricept, which don't work. But the goal of Aricept is supposed to increase the neurotransmitter acetylcholine in the brain, which is very important for the cholinergic system, which is important for memory production. Well, it turns out that estradiol is critically important for the production, the proper function of the neurons that produce acetylcholine for memory. And what about dopamine? It turns out that estradiol is also really important for the production of dopamine. So it just goes on and on. It's like, what can estradiol not do? It can do everything. And then serotonin, let's see. Yeah, it's covered on my slide. But so serotonin, there are serotonin neurons that are actually supported by the production of estradiol in the brain, or that's, remember, for women, there's not enough. So coming from the ovaries, of course, it's fine during the reproductive years. But what happens is that you need to have some adequate amount of estradiol to make serotonin. And from serotonin comes melatonin, one of the most potent replaceable antioxidants of the body, and of course important for many, many functions, glucose regulation and sleep, and its antioxidant functions. So, and just as a note here on this slide, it says, estradiol and progesterone increase the expression of the genes that produce superoxide dismutase, which I mentioned, and other growth factors. So and this is just showing that there are receptors throughout the immune system for estradiol, and it functions to keep the inflammation down in the brain. So inflammation underlies almost all of the issues related to aging. That's why they call it inflammaging, this inflammatory process of aging. But if you have proper estradiol, the immune system is properly regulated. So you don't have this uncontrolled state of inflammation. And if you give estrone, it will actually only feed that inflammatory process. Microglia, the specialized macrophages of the brain, have two basic states of being, sort of the quiet surveillance and then the activated, where they start releasing their matrix metalloproteinases and these other very toxic enzymes, and they go crazy and they go into that activated state on a regular basis. And you can see what they can produce is like the whole array of inflammatory cytokines. And as much as I love estradiol, I do not want to belittle the importance of all the other hormones. So progesterone, which so many people think only is necessary in postmenopausal women to prevent uterine cancer if they have a uterus, that is totally not true. Progesterone, like estradiol, has receptors throughout the body. And in the brain, it also is very neuroprotective and works on all these areas: neurogenesis, neuroprotection, helps with regeneration, helps prevent seizures. There's actually a condition called senior seizures, which is due to low levels of progesterone in the brain. It helps maintain myelinization, and it helps deal with traumatic brain injury. It helps with mood and cognition and mitochondrial function as well. So in this slide, I just have a lot of the other benefits of progesterone. So they've done a lot of studies in rats where they create hypoxic injury to the brain, and progesterone to the rescue. It helps with traumatic brain injury. It also increases brain-derived neurotrophic factor. It helps to maintain, like I said, the myelin. And it also is made in the brain. So it's a neurosteroid. All the steroid hormones that can be made in the brain are called neurosteroids because they're so important to brain health and function. But remember, the problem is women never make enough after menopause, and neither do men if their testosterone levels get too low. So just as a little review here, we have it shows like an ischemic brain, and it shows E2. E2 is the symbol for estradiol. And you see that it activates and works on the different immune cells, microglia, astrocytes. And when you have trauma to the brain will start increasing aromatization to make more estradiol and also make more progesterone. So the reaction of the brain to trauma is to make more of these neurosteroids. And then it works to maintain the inflammatory response so you don't have inflammation out of control. The equivalent of what they call the cytokine storm with COVID. We don't want a cytokine storm essentially in the brain where you get so much damage and scar formation and so forth. So estrogen in the form of estradiol and progesterone to the rescue. That's why women who have such high levels of estradiol, when they have brain trauma during, or they have any sort of injury, traumatic brain injury in the premenopausal years, a comparable injury to a man, the men will fare less well because the hormones of women are so wonderful for brain health. And testosterone is also a plus for the brain. And I mentioned men and women have quite different brains. We do have some differences in how we perform in general on verbal and perceptual tasks and visual, spatial, and motor tasks. And so there are some differences, but they're not like superior or inferior. They're just different. And we know that, of course, testosterone has a big impact on cognition and mood. Men who have really low testosterone are going to have cognitive problems and mood problems. So we don't want men to be overly macho, but we certainly don't want them to become like little wimpy, crying, demented people. And we need that wonderful testosterone in men and women. They need testosterone too. And so testosterone has many, many functions in the brain. It not only is converted to estradiol, but there also are specific receptors in the brain for testosterone. And one of my concerns for men who use drugs like Propecia, which block the enzyme 5-alpha reductase that converts testosterone into dihydrotestosterone, like what is that long-term doing to their brain health? I really worry about that. And we don't have really enough data that I'm aware of to look at what drugs like Propecia do to the brain of men. And for example, beta amyloid is directly related in men to their testosterone level. So the last thing we want is to create a bunch of beautiful head of hair on demented men. Not the goal. And testosterone also has a lot of benefits for the vascular system, some of which is by converting into estradiol. Arteries actually contain the enzyme aromatase. So men have loads and loads of estradiol in their arteries, but there's also direct effect as well. So it's a complex interplay between conversion to estradiol and the effects direct of testosterone. So brains are complicated, and I don't have time because we'll be here all night, and I don't think you want that. But it's not just about that, of course. These hormones also have effects on the autonomic nervous system. And women have a lot more autonomic dysfunction, like they get hypotensive, postural hypotension more readily, more tachycardia. Only women, or 90% of cases of Takotsubo, which is broken heart syndrome, occur in women postmenopausally due to dysfunction of the autonomic nervous system with over output of sympathetic versus their parasympathetic. And that is occurring throughout the body, not just in the heart. And there's a role of the endocannabinoid system that are very interrelated. And I know you love talking about the endocannabinoid system. These are lipid signaling agents that are throughout, they have receptors throughout the reproductive tract of women, also men, and they're also on many other cell types, of course, the brain, the gut, and the immune cells. So all of this is completely interacting with hormones. Circadian rhythm, there are receptors for estradiol on the suprachiasmatic nucleus neurons to help regulate proper circadian rhythm, which after menopause, women become basically jet lagged. They have circadian rhythm dysfunction, which is associated with all metabolic dysfunctions that get worse, as well as cognitive and mood get worse. And the immune system I mentioned, and the whole gut neurological system, the gut microbiome. After menopause, women have dysbiotic gut microbiomes develop almost immediately, which causes more leaky gut, more inflammation. Systemic inflammation creates neuroinflammation. Those cells cross into the brain, creating more neuroinflammation. And all of these hormones help to regulate all of these complicated systems to maintain proper brain function. So neurodegenerative diseases is a huge problem. We have an epidemic, and who the heck is going to pay for the cost of all the demented people that are going to be present in the country over the next 25 years? So we have all these different neurological problems. By the way, the eye is part of the brain. So when someone has glaucoma, which is more common in women, but can happen in both genders, when people have macular degeneration, that is a brain problem. Okay, the eye is part of the brain. So that's a sign that you have brain dysfunction. You have inflammation and degradation of the brain when you have those types of eye problems. So recognize that the eye is part of the brain. And so all of these issues are huge, and women do not get more Parkinson's than men, but they do have tons of vascular dementia, 2.5 times as much Alzheimer's. Senior seizures can happen to males and females, predominantly related to progesterone deficiency in the brain. And vision and eye health, of course, is by gender. So what I recommend is my 7 steps to optimizing health in women, but this could apply to men. So we want to nurture the gut microbiome through eating a diet that's high in probiotics and prebiotics. So lots of different fibers and polyphenols, which have like their own unique dance with each type of microbe. So diversity of the rainbow, different kinds of vegetables, plants, and please don't vilify legumes anymore, if you ever did, because they're like wonderful for the gut microbiome. And we want to live with our circadian rhythm, eat at the right time, don't eat late at night, don't skip breakfast, please, and eat, a bowl of, fat-laden coffee. That's not my idea of starting the day off well. And I love all kinds of fresh fruits, of course, whole foods. Don't vilify fruit. I have a new motto also, don't be afraid of fruit. It's eating too many apples is not what caused the diabetes epidemic, I can assure you. We want to get sunlight, that's happy medicine. So sunlight actually has receptors in the brain that then send signals directly to the serotonin neurons that help you to feel happier and then to make melatonin and sleep better. And we need to have adequate sleep. So sleep hygiene is so important. And exercise, like the magic medicine, so important. You want to do aerobic and you want to do resistance training. And then, of course, avoid toxicants as much as possible, by buying things that are organic and not using poisons in your home and spraying with pesticides and so on. And then every plan is personalized with hormones. I love estradiol, but I do not use other forms of estrogen. And then targeted supplements, which, are many, like Dr. Bredesen uses. So when you do all of these things and understand and utilize estradiol and progesterone and some testosterone when they need it, that you can help every one of your women patients to optimize their life quality as well as lifespan. And a little plug for me, I have my newest book out, not quite a year old, is called Menopause, 50 Things You Need to Know. It's like a little encyclopedia of medicine relating to menopause. So I hope all of you have a wonderful evening, and thanks for inviting me to join you tonight. So
wow,
that's my little brain picture there. We don't want a blackout of a brain.
That was absolutely beautiful and powerful. And we do have some questions. Do you have time for a couple questions?
Sure.
Okay. That disappeared.
Well, I didn't disappear, did I?
No, you're good.
I just took off my slides, unless did you want to still see it? No.
No, I think we got it.
But anyone who wants to reach me, I'm here for you, if you want me.
Okay. How soon can you start estrogen after a stroke?
Well, if you go by conventional treatment, it's contraindicated, which is absurd. So, as far as I'm concerned, you always have to be careful about, legal schmeagle, because somebody might sue you. But, I would probably say a month. But the reality is that there's no peer-reviewed published literature to support what I just said. Now, in terms of clotting, I already told you that it's estrone that increases the clotting risk because it's like pro-inflammatory. Well, what about estradiol? Well, estradiol increases a whole other group of enzyme systems called the prostacyclines. And prostacyclines actually reduce platelet aggregation. They actually reduce it. And of course, increasing nitric oxide, which estradiol does, improves dilation of arteries. In fact, there were some studies where they did estradiol infusions during the actual event of a myocardial infarction, and they did better. They had better perfusion of the myocardium. It's just for whatever the reason, like nothing caught on after the Women's Health Initiative, and they, poor estradiol was vilified as if it were poison. But the reality is that estradiol actually vasodilates and it maintains a non-platelet aggregation environment. It does not cause blood clotting. It does not initiate an inflammatory response for no reason. It would only be in response to a pathogen or damage. So in my opinion, but if you would, you can start it like in a month. The reality, you could start it like the next day. The reality is that I don't want anyone to get sued. And the stupid dogma is that estradiol is contraindicated in anyone who's had a stroke. So I need you to know the facts, and then I need you to know the legalities.
Amen. What is your acceptable level for estrone, and how do you move estrone out of the system?
So I actually don't measure estrone because, interestingly, it is not as stable as estradiol. And so you can't know what it is like an hour from now if you measure it this hour, because it can change. So I go for a stable estradiol, and then I look at inflammation, because it's inflammation that causes the overproduction of estrone, because inflammation upregulates the enzyme aromatase. Now, it's for the purpose of controlling inflammation. Like, for example, if you are a healthy person and you're younger, you're going to have more testosterone, you're going to make more estradiol, like in your skin. If you have a burn or a trauma to your skin or to your head, you're going to make more estradiol. But when you're postmenopausal and you have chronic unrelenting inflammation due to leaky gut and dysregulation of everything, then you're going to have chronic production of estrone. Now, estrone is made in breast tissue because the breast tissue has a lot of the enzyme aromatase. And why would that even be? Because when a woman has a baby, her estrogen level goes to nothing from her ovaries for quite a few months, typically. So her ovaries shut down during breastfeeding, especially the first 6 months or so. So if a woman gets a breast infection, mastitis, while she's breastfeeding, you don't have enough circulating estradiol. So the breast tissue starts to convert and making estradiol in the breast tissue to help support the resolution of an infectious inflammatory process in the breast during breastfeeding. But in menopausal women, you still have that capability. So if you have a lot of inflammation in a postmenopausal woman, she will upregulate aromatase, but she's going to make predominantly estrone. Most all breast cancers that are estrogen receptor positive are positive for the alpha receptor. That's why they give things like tamoxifen, and that's why estriol became sort of like a superstar once upon a time, because it works on the beta and not on the alpha, and the breast cancer is alpha. So, and when you have a lot of beta, it downregulates alpha. So estriol is probably good as an antidote to breast cancer. The problem is it's not really the ideal estrogen for a postmenopausal woman for all those reasons, that it actually is not good for the gut microbiome, and it actually doesn't regulate the brain properly or anything, because like the arteries are actually predominantly alpha. Like the lining of the arteries, the intima is actually predominantly alpha receptor positive, all different organs. And we don't want to down-regulate our innate immune cells in the postmenopausal woman so she can't fight off an infection. We don't want to do that. And also cancer surveillance. We don't want to do that. So don't give estriol in menopause, but we want to understand what it does in the body. And in the breast, it's, it's anti breast cancer because it upregulates the the beta receptor. So a lot of people used to call estriol a weak estrogen. It's not a weak estrogen, it's just a different estrogen, and it works on different receptors. But it's not weak, it's very powerful for what it does.
Okay. What do you suggest for women in breast cancer remission with mild cognitive impairment?
Well, once again, now we have the legal and we have the science. So if you have a woman who has not developed metastatic disease, okay, so she doesn't have metastatic breast cancer, and particularly, it appears that she was cured, there's nothing really going on. And we know there's a tremendous amount of overtreatment of like ductal carcinoma in situ, where they have so much, ridiculous excessive treatment. But in my opinion, if a woman doesn't have metastatic breast cancer and she's fully informed of, the conventional lack of wisdom versus the science, then if you give proper consent and you document it, I have patients who've had breast cancer that I have on estradiol, and I would treat them like anyone else. So I wouldn't purposely give them a tinier dose. That doesn't make, if you're going to do it, just do it right. Okay. So we're not going to try to remember, estradiol has different effects at different levels. A very, very low level of estradiol is going to be more pro-inflammatory because it's just too little. So don't give like a whiff of estradiol because you say, well, she's had breast cancer. And it's really interesting. There's a lot of things that estradiol does that most oncologists don't know. For example, there are certain tumor suppressor genes that are actually activated by estradiol because nature didn't really want women to get cancer. And also there are certain genes that regulate cohesiveness of cancer. So that, because cancer of breast cancer doesn't metastasize based on size. That's like a total fallacious belief system that metastasis is based on size. It's not, it's based on cohesiveness of the cells. So you can have a very tiny breast cancer and the cells are non-cohesive, so they break off and travel through the lymphatics or the vascular system. You can have a baseball-sized breast cancer and it's only locally invasive and it never metastasizes. That's the unfortunate thing about mammography, is that it's based on a fallacious premise, which is that metastasis is based on size, when it's really based on cohesiveness. And what's interesting is that estradiol actually activates the genes that promotes cohesiveness. That's why there had been data, for example, that women who did get breast cancer, if they were on estrogen, they had less aggressive, because estradiol helps to maintain cohesiveness. And so that's a really interesting thing. So when you give progesterone and estradiol in a rhythmic way, so that you pulse the progesterone, so that you get the shedding of the lining of the uterus, even though women will bleed, you just tell them it's a sign that things are working, okay? If you give estradiol so that you don't get bleeding, and you give very tiny amounts, and you give daily progesterone, you're kind of going against the whole purpose, because estradiol is about growing and repairing and nurturing. And if you give such a little amount that you get no growth of the uterine lining, what makes you think you're growing neurons or bone or anything else? So think about, why are you giving the hormones? If it's to suppress night sweats or hot flashes, only a whiff will be needed. But if you're really trying to make sort of a regenerative approach to the female body, a maintenance, then you have to give enough. And you can say the uterus is not the target of giving hormones, but if you have a uterus, you can use it as a gauge. So if you grow the uterine lining and then you shed the uterine lining with progesterone that's pulsed and the estradiol that's in an amount that's sufficient to grow enough uterine lining that it will shed and create bleeding, then that's a sign that you can tell your patients. That's a sign that the estrogen is actually growing things. If it's growing, it's repairing, it's renewal, okay? So think of it also when they have the shedding of the lining as purging of crappy old cells. So if they think of it as a cycle of birth and renewal, then they won't think of it as a pain in the butt.
What
Wow.
dose would you give?
Well, that's the interesting thing about estradiol. Our skin was not designed as a hormone delivery system. So the amount that you get in is totally variable. So like when they did the initial estrogen patch studies, I was actually involved with the company that was doing that. I wasn't part of the study, but I was involved in education very early on. And I looked at all the original studies and it looked like a scattergram. So you could give 10 women the same estrogen dose, the same patch, and you get totally 10 different levels from very little to medium high, never super high. So it's like they just went like this and you get spots all over and then they just draw a line through the middle. So you have to measure. Now, if I give an estradiol patch, if someone is right at the beginning of menopause, I'll usually give a 0.1 because their body's used to it. If they're like further out, I usually start lower with like a 0.05 because their body's adjusted to not having hormones, which doesn't mean that that's a good thing. It's like people who are starving, you don't want to give them a 5-course meal, right? You got to help their bodies to adjust to eating. So I help them to start lower and then work up. But my goal is to monitor. If I use a patch, I monitor the estradiol level the day after I put the patch on, sort of for an intermediate level, because it's not going to be exactly the same every day of the patch. It's not that good, you know, as time release. And I'm looking for a level that's at least a 50. This is picograms per mil, at least a 50, and typically under 150. So, you know, getting as close to 100 as I reasonably can, but at least over 50. They've shown that if you have less than 50, it does nothing for the vagina. If it's not doing anything for the vagina, I don't think it's doing anything for anything. So, and that's the other interesting thing about the timing hypothesis, that you can't give hormones after 10 years outside in menopause. That makes no sense because we know that, and it's encouraged by like the North American Menopause Society to give hormones, estradiol, to women who are any age, like 75, 80. It's okay to give it vaginally. And what happens to the vagina? It gets better. So if the receptors in the vagina can still function no matter how many years out you're in menopause, why should I think that's a unique organ and no other organ can respond in an appropriate way? I think you just have to kind of, you know, tease it back to life. The same thing when women have been on birth control pills for their entire lives, which I see all the time. They're put on when they're 13 and 14, and then they go off in their mid-30s to try to get pregnant. So they've been on their entire reproductive lives. None of those hormone receptors are going to work right because they've all been disused or malused. So after menopause, the hormone receptors definitely degrade, but they're not dead, and they can still be resurrected to a reasonable degree by giving the hormones. But I would start lower, and my ultimate goal is at least a 50 and under 150.
Would you give them a biased, or you would
No,
just
I
use
never
estradiol?
ever, knowing that what I know about estriol. Estriol is made, by the way, it's converted in reasonable amounts naturally from estradiol. So every reproductive age woman does have this totally balanced of estrone, estradiol, and estriol. But we do not want to create like an artificial physiologic state of being. We're not trying to create pregnancy in a postmenopausal woman with all the effects of pregnancy. Remember, pregnancy is a pro-inflammatory state. It actually increases insulin resistance. And that's why pregnancy is a stress test for women. And many women are failing that test. The incidence of pregnancy-related complications like gestational diabetes, preeclampsia, gestational hypertension, and preterm deliveries, they're just going through the roof. I mean, pregnancy-related complications, because it's a stress test and they're failing. Because the hormones of pregnancy are pro-inflammatory, because women in ancient times had to put on fat really fast, so they needed to be insulin resistant. Why the heck would we want to create insulin resistance in our postmenopausal women? So estriol is very unique in its effects. So we don't want to recreate that. The fact that the estrogen that is responsive to breast cancer is the alpha receptor doesn't mean we should give all postmenopausal women a whole pile of estriol. The body will convert estriol as needed, but the ultimate goal is to keep inflammation down. If you keep general body inflammation down, you won't have all this inflammation in the breast tissue, you won't have aromatization and the production of estrone locally in breast tissue. You won't have that if you keep inflammation at bay. And keeping physiologic levels of estradiol will keep inflammation at bay. It will help maintain a healthy gut microbiome. It'll help maintain vascular health. It'll keep the immune cells properly regulated. So by giving estradiol, you will prevent breast inflammation. And there was a study that came out about 2 months ago that looked at women who'd been on hormone therapy. Now, this is different kinds and doses and so on. But what they found was that women who'd been on hormones in menopause had a lowered incidence, like by over a third. I mean, really significant, 30-something% lowered incidence of like 7 different kinds of cancers, like pancreatic and lung and ovarian and uterine and breast cancer. All these cancers were reduced. And yet that didn't get it. Where was like the publicity for that, you know? Because you're improving the status of inflammation, and inflammation drives DNA breakage. And in a proliferative environment, you end up with the promotion of cancer. And estrogen is proliferative, but it's in a controlled environment. It's about growth and renewal. It's only when you have chronic inflammation that it gets subverted, you know, from its normal function, and it becomes, you know, sort of a co-conspirator in breast cancer when it's produced in large measure. There was a study that was done that nobody paid any attention to, like probably a decade ago, where they gave women with breast cancer an aromatase inhibitor, which blocks the production of estrone in the breast. And then they gave them estradiol. And guess what? Those women did great. So think about that. Why are the oncologists not doing that? Block the production of estrone by giving aromatase and then give them estradiol. You know, seems so logical when you think about it, right? But that's not what's done. Why can't you do that? You get rid of the estrone and then you give the woman the estradiol that she needs to maintain brain health and bone health and vascular health. You know, like, I know you feel like I do, like we live in a parallel universe where science is ignored by the other universe, you know, so, you know, but, you know, I don't want anyone to get sued because, you know, I love, you know, the science behind this, you know, so I don't want to get anybody to get sued because we live in a crazy litigious world and doctors who think out of the box are punished. You know, even when it's evidence science-based, and it's a little scary. So, you know, we have to decide, you know, how far do we go out of the mainstream, you know, to help our patients and so on. And make sure when you do that you document that this was fully discussed. And by the way, I do not have a like a consent form for giving women hormones. I don't have a consent form for any drug I prescribe. I mean, you know, like, if I give an antibiotic, we know there's side effects and risks with every drug. I don't have people sign a consent form for every drug I prescribe. I mean, I don't do that. So I don't consider that you need, just the fact that you would have a consent form, which some people have, means there's something unique and crazy. Or why are you having them sign a consent? Are they part of some weird study? So I just document in very simple words. By the way, I'm also a forensic medical expert. So I defend doctors against the medical board. I've been in the witness stand many times in court and in medical board hearings. So, you know, at least a lot of things get drilled into my head about, you know, documenting. So just document that you had a thorough discussion of all risks and benefits. And that's all you need, because then if it ever came to something, you could say, my standard list of benefits are the following. My standard list of risks are the following. You don't have to spell them out because inevitably you'll forget something. So don't spell it out. That's like great for the attorneys that are working to put you in a bad place. Okay, so just be general, don't have a consent form, just document that you discussed in great detail all the potential risks and benefits. The patient is aware of all the options and wants to proceed down this avenue of treatment. At least
What
that's
dose
my
would you
opinion.
start? What dose would you start the patients? You have
Well, if it's somebody who's recently menopausal or they're in the transition, I would start them for an estrogen patch at 0.1. If I'm giving them like Divigel, I would start at either 1 milligram or 1.5. If I'm doing compounded, that is probably the trickiest because of the absorption is going to vary with the location. But I would probably start at like 1 milligram twice a day and then follow the levels and see. And then where you place it, there's no data, right? There's just no data. If we think if you want to absorb it the fastest, you're going to put it around like the inner labia minora because it's thin, behind the knees, like on the forearms, that kind of place will have absorbed faster. And then perhaps you need to apply it more often because maybe it won't have like long acting. And then theory is that if you put it on a fatty area like the inner thighs, you will have maybe a slower release. We have no documentation of any of this. So this is what I call the art of medicine, truly. You've got to try different things. You've got to follow. And I always tell my patients that we're going to go on a journey together because there is no like rote, everyone does the same protocol. Nobody can look at somebody and say, I know just the dose you need. How would they know that? I don't know what, and by the way, people can change over time as their skin thickness changes, their vascular system, to the skin changes and so on. By the way, back in the 1990s, there was a ton of research on estradiol and the skin. Oh my gosh, it is so anti-wrinkle. Not only is it anti-wrinkle, it promotes healing. They had wound centers that were using estradiol. All of this research kind of dried up after the Women's Health Initiative. So if women are doing compounded estradiol, I tell them sometimes, look, if you want, take some of that estradiol, put it around your eyes, put it like on your upper lip. It's going to absorb through your skin on your face. Okay, I've done personal testing on me, okay? And it does absorb just as well as anywhere else, maybe more. And then you get, because we have published data on how it reduces wrinkles in just 2 weeks. You see, my wrinkles are so much less. Or at least I think I tried, positive thinking is good too.
I definitely second that. That leads into our next set of questions. What is your cutoff for the cholesterol to be still healthy and not affect hormone production if you don't promote starting low doses on hormones?
Oh, we have data on that. So that
Okay.
I have some data, 150, total cholesterol below 150. In women who are reproductive, that's more associated with like hypothalamic amenorrhea.
Okay. And then
So
I
you
think
want to get a cholesterol at least a total of like 150.
at least 150. And I think you may have answered this on the estrogen, but what are your recommended doses for estrogen, progesterone, and testosterone?
Well, the estrogen, like I said, is variable, and I usually start with a patch of like 0.1 or the Divigel like 1 or 1.25, and the estrogen, if I'm doing compounded, like maybe 1, if it's a younger person, like 1 milligram twice a day. If it's a really older person, I could start like 0.5 milligram once a day. I'm going to, for people who've been away from estrogen for a long time, I'm going to go slower. And of course, we have no data, of course. And for progesterone, I tend to use the pill. So this is not very scientific in terms of customized. I usually do 200 milligrams for 14 days every cycle, every month. But if they don't tolerate that, that happens. There are some people that cannot tolerate oral progesterone because of its conversion, into like GABA related stuff, which is great for sleep. Some people say, I love being on progesterone. I never sleep so well except on those 2 weeks I'm on progesterone. But then I will use cream, but we have no guidelines for cream at all, nothing peer reviewed. So you got to watch the uterine lining, and everyone who prescribes hormones needs a friend that knows how to do like uterine biopsies that isn't going to badmouth them. Like if some woman, they're having all kinds of irregular bleeding, which can happen, because women can be 25 and have irregular bleeding, right? So, we're not giving hormones that are the same as having a new pair of 21-year-old ovaries. We're giving in a concocted way to do better. Remember, when I give hormones in menopause, I'm not recreating a 25-year-old's environment. I'm just doing better than, like a 55-year-old's natural environment. So we're doing better, but it's not perfect. And it's not hard to get into bleeding issues. If you're giving adequate amounts of estrogen, people give like subtherapeutic doses so they don't have bleeding. Well, then what you're giving is subtherapeutic effect. But if you're going to give enough to actually cause growth and, regeneration of tissues and so on, then you're going to potentially have some irregular bleeding. So you need someone that's on your side that can do a uterine biopsy and won't badmouth you all the way to court. Okay. So, like, I feel so sorry for people who don't have like a friend. Like, as an OBGYN, I do this myself for my own patients, and but everyone needs to have some OBGYN who's not going to say, what the hell are they giving you? And do you realize that this can kill you? It's going to give you breast cancer, and like, I'm going to report this doctor, it's like, oh my gosh. So, everyone, you need to find someone in your community that you can work with, that is going to be your friend. I don't know how to deal with it otherwise, because you can't ignore, like, there was a doctor in LA who ended up, was on the front page of the LA Times because she didn't do a uterine biopsy and she kept fussing with the doses and everything. And it turned out that patient did have uterine cancer. Being on hormones lowers your risk. It doesn't remove the risk. So anyone can get anything, whether you're on or not on hormones. And you got to make sure, like, she was on the front page of the LA Times for neglecting the proper care of her patient, because she was not a doctor who could do uterine biopsies, and she didn't refer the patient until finally some relative said, you need to go see a gynecologist, who then badmouthed the other doctor to like crazy, did a biopsy and found cancer. And then, the whole thing was a giant lawsuit and a medical board and front page. So find a friend that you can work with. So don't like mess around with irregular bleeding for too long. If they need a biopsy, they need a biopsy. It's a 2-minute procedure practically in the office. And 98% of people can do it and successfully. Now, there's always a few that have stenotic cervix, and that's another story.
Okay, I think you may have answered this already because I heard biased mentioned, but do you like biased compounded?
No, because estriol is going to be made naturally from estradiol, and let nature do its thing. We have to stop thinking we can micromanage everything in the human body. I'm sort of like a big picture kind of person. There's the lumpers and the splitters. I'm a definite lumper. So I'm going to try to manage like the big picture, like the big global hormones. Like, now I'm not talking against peptides, but I don't do peptides because I think that in general, trying to micromanage peptides is a little bit daunting, to say the least. And like, peptides are doing different things at different times in different parts of the body. But I think there's going to be a role for that. But I'm not smart enough to know how to micromanage peptides or like metabolic byproducts of things, So I'm so simple-minded. I just give the lifestyle stuff like I have on my 7-step, and then I give, basic hormones like thyroid hormone. In terms of testosterone, we have no data on that either, and there's nothing but compounded. So I've done just from my own experience, and I usually start with 1 milligram a day of testosterone. That's it. I just start with 1, and then I see where they're going with that. Nobody appreciates getting acne when they're 50 something, So just start with like 1 milligram and then see how you do with that. And that's, just simple, basic. And the vast majority of your patients, just by doing like the basic lifestyle stuff and giving them basic hormones, estradiol, progesterone, plus minus testosterone, plus minus DHEA, by the way, which there's a lot of data on DHEA and female bone health. So it's very good for bones. So wow. DHEA, and you want to get to like maybe a level, like if someone has a level under 100, certainly under 50, they're probably going to benefit from going on DHEA. And so it's a very good anabolic steroid. And so, I just do very basic stuff, but most people are eating a crap diet. They're living poor lifestyle, And if you give them the basics, they'll be like 99% better. And that extra 1%, I'm not sure what to do with, but I'm happy I'll settle with 99.
You know, with
Dr.
all those,
Felice,
oh, go
great
ahead.
presentation. One of the good ones. And I'd like to invite you to present on Monday when you have time. Many times I'm texting you and asking you for your presentation, but it
Oh,
seems
who's
like I have
talking? I don't know who's talking to me.
Halasa, Dr. Halasa.
Oh, okay. Yeah, I did recognize your voice, but I just wanted, because I don't have everyone's picture up on my screen. But
Right.
sure, I'm happy.
Yeah.
It's just that most of the time I'm still seeing patients around 5, but I was able to, fortunately, I had somebody, I usually do telemedicine until like 6. I'm a little bit of a workaholic, guys. I'm trying to cut back. It's my own, my own problem that I need to deal with. But, but I'm happy. I just need a lot of advance notice, because otherwise I have patients still booked usually at 5 o'clock when you start, but it worked out pretty well today.
I have
I
one more
will
question
se-
regarding stroke patients. If patient is 3.5 years past stroke and has not recovered, do you think it would help? It's a male patient.
Oh, no, I would not. Well, you mean testosterone?
Yeah, no, estradiol.
Oh, I would not give estradiol to a man ever.
Men, what about testosterone?
Well, I mean, testosterone, I would be in favor of, but of course, you're going against, once again, dogma of, our medical world.
But if they have a low testosterone, would you do that?
Yes, and most men who have strokes have very low testosterone. That's why they got a stroke, because they have very low nitric oxide. They're pro-coagulant, they're pro-inflammatory, and testosterone is very protective for males' bodies. It's like, I don't understand. It's like, what males are the healthiest? The ones who look like they have the greatest biceps and 6-pack, and they have really great testosterone. They're not the ones who are like sick and demented. It's the elderly who have an testosterone level of like 110. It's like, and that's real. I mean, they actually have really low levels in like a little over 100 and such. And there's more data showing that giving very low testosterone males testosterone actually helps. The problem is the ones that aren't like as low as like 120, or 130. Those men, they don't want to give it. Like 300 is not adequate, but it's like so unfortunate that, that's why I'm trying so hard to get the word out, that hormones are our friends. Like endocrine disruptors are the enemy. People are afraid of the wrong things. Like, be afraid of, the food that you're getting served. Be afraid of the plastic and the takeout containers your food is packaged in. It's like, be afraid of the air you're breathing and the water you're drinking, as we unfortunately know, from what's happened in Jackson, Mississippi. Like, be afraid of the things you're supposed to be afraid of and then try to do something about it. Don't be afraid of bioidentical hormones. It's like, what? It's like crazy. It's like, why would you be afraid of thyroid hormone? I mean, like,
Why you don't give HCGC, human chronic gonadotropins, instead of testosterone with that patient with stroke? Do you think it's better than testosterone, or just giving straight
well,
testosterone?
here's the thing. Most of the males who have really low testosterone and they're a little bit older, like 50 plus, most of them have like what you might call testicular failure, like their testicular function is really not capable, kind of like the menopause, the man version. So that if you test their gonadotropins, FSH, LH, they'll be quite high. So if a man has elevated gonadotropins, then it means that he has menopause, and HCG isn't going to do a darn thing, because they already have high equivalent of HCG and their LH is already high. So if it's low, then yes, you can give that. But, once again, there's not long-term data. There is maybe just short-term, but not long-term. And so that the same thing with like giving Clomid, which is an estrogen receptor modulator. So basically it's an endocrine disruptor for estrogen, but it can trick the brain into making more LH, and then men will produce more testosterone. But any young male who doesn't have high gonadotropins, but he has low testosterone, it's from a combination of endocrine disruptors and chronic inflammation. Inflammation will lower the production of testosterone. So, that's where we want to get inflammation down. And one of the best ways for men is, for that type of man, is exercise and getting that inflammatory visceral fat off. So, all the lifestyle stuff. And you can see, and doing like things to upregulate detoxification pathways so we can get rid of some of those endocrine disruptors, hopefully. The ones that are the forever chemicals, I don't know how to get rid of them. That's why they call them forever chemicals. But, do the best we can and tell them to adopt a more, clean lifestyle where they don't, have a lot of plastic and flame retardants everywhere and spray with pesticides. I've seen people pick up cans of pesticide and just start spraying ants like in the air.
Right.
It's like terrible. And I keep yelling at people at swimming pools to stop spraying the entire population of the swimming pool with the sunscreens. Those are poisons.
Dr. Felice, is testosterone is converted to estradiol or estrone by the fat tissue of the belly for the man. Do you see a difference there of conversion of testosterone, or all the time it converts to estradiol? I think
testosterone is converted into estradiol, but for men, they have a lot of adrenal androgens too, the DHEA, DHAS, and those are converted into estrone. But we don't want circulating. I mean, as much as I love estradiol, I don't want a man circulating lots of estradiol. That is not our goal. By the way, men who have what you might call like men boobs, that's a sure sign of a lot of inflammation in their bodies, because they're using their own breast tissue and other peripheral fat tissue to make all of that, estrogen, and it's circulating. Sometimes you can get an estradiol level on a man and it could be like pretty darn high. It's like crazy high. Like, what the heck is this? It's because he's so inflamed and he's making all that estrogen of different kinds, and we don't want that. I mean, that's why we never give estrogen to a man. Maybe there's some special circumstances, but I'm very old fashioned. I believe men get testosterone and women get estradiol plus the others.
What about development of melasma from using the cream on the face?
Well, estradiol does not promote melasma. That's an inflammatory. People who get melasma, that's inflammation in the skin. That's a sign of inflammation. And it's predominantly promoted by a pro-inflammatory state. Remember, I told you that pregnancy is pro-inflammatory. So pregnant women get it, and women on birth control pills get it. But women who use estradiol and put on their face, they don't get it from that. Okay, they're not going to get it. I can't say it's curative. I don't know of any data that if you put estradiol on your skin, you'll cure melasma, but that would be an interesting study. I don't think anyone's done it.
Wow.
But in
Dr. Felice,
general, it actually reduces discoloration. It's very rejuvenating to the skin.
Dr. Felice, you mentioned that pregnancy causes all those hormones, which are stressful, but at the same time, we know those hormones, including oxytocin, it's actually protective against cancer. And we find out ladies that are not pregnant, they have high risk of breast cancer at the end of their 50s or 40s.
It is complicated. So it's a complicated system. Nature makes it so that when all goes well, we're anti-complication and we're anti-cancer. Okay, so there are many systems in the body, like estrogen, progesterone, which is very high. So remember, in pregnancy, it's not just estriol. The amount of progesterone is sky high progesterone. You don't do that in women who are postmenopausal. No one's giving enormous quantities of progesterone to postmenopausal women. And progesterone has its own anti-inflammatory effects. Progesterone is very interesting in that it downregulates the production of the endocannabinoids, but on the immune cells, it upregulates their receptors. So, I mean, that's how we prevent in a healthy woman endometriosis. So there's a huge interaction between progesterone and the endocannabinoid system. It's very complex, there's no question, but a woman who goes through healthy pregnancies doesn't have complications. It does apparently reprogram a lot of genes. We know that you can actually have epigenetic modification from pregnancies that actually help prevent breast cancer in some way by genetically having different expression of genes in the breast tissue, and probably involving things like the cohesiveness and so on. Although there's like pregnancy is amazing, so every woman should hopefully have a few pregnancies, but not
You
every
say
woman
it's related to oxytocin. Is that you agree with that? That's
well,
oxytocin itself.
oxytocin comes out when you're in labor. I mean, you don't have high levels of oxytocin all the time, but oxytocin is, it's sort of a blend or on the boundary between a peptide and a hormone, because it's a relatively short chain amino acid. But oxytocin, like all hormones and peptides, is a multitasker. So oxytocin is very important in sexual function. It actually, like with sexual excitation, it actually promotes proper orgasmic function, and it suppresses appetite. And you have different levels of oxytocin in various nerve bundles in the brain versus peripherally. I mean, it's really, diverse amounts in different parts of the body, and oxytocin does help regulate appetite. So when people are sexually excited, they lose their appetite. Nature does that so that, because nature, remember, it's all about reproduction. So they don't want people thinking about, I want some, hot dogs when they're in the middle of having sex, so they say, oh, forget this, I'm going to go to the store and buy some hot dogs, so your appetite is suppressed. So oxytocin is an appetite suppressant, it's a sexual enhancer, and it's for love and bonding, because it's all about successful reproduction. But, and we then try to use oxytocin perhaps in ways that it was never quite intended, because we're looking for a therapeutic effect. So we just need to know when we're using a hormone to try to replicate human physiology, and when we're trying to actually use it in some way as a drug to change the body's physiologic response in a way that you think you can control. So I'm open to everything, that is for treating people who have specific illnesses. But when it comes to just like hormone replacement in menopause, I try to be as physiologic as I can.
When it comes to testing, as far as metabolization, do you test with, I've seen some people with Dutch tests and stuff. Do you test at all for the metabolites? You were saying use only estradiol, but are you concerned with that at all?
You know what? I don't. And many women who are going through menopause, and not even in menopause, younger too, but in menopause particularly, they have non-alcoholic fatty liver disease. So when in doubt, especially if you have insulin resistance, weight loss resistance, get an ultrasound of the liver, and you'll find a lot of non-alcoholic fatty liver disease. So I just assume people who look unhealthy and have inflammation markers probably are not the best detoxifiers. So I just assume that they need help. So we start every patient who's willing. I don't make them, but I try to get them. We call it a reset, but some people might call it detox. But I don't use the word detox because the conventional medical world rolls their eyes, so I call it a reset, an anti-inflammatory reset. So we're trying to upregulate detoxification pathways, help the gut microbiome. We know that phase 1 detoxification starts in the small intestine, right? So we want to work through every part of the detoxification pathways to try to help, because But it's one of those catch-22s. You won't have proper function of the liver or the GI tract or detoxification if you don't have adequate estradiol. And you're not going to get adequate estradiol in a postmenopausal woman unless you give it. So it's one of those catch-22 things. So you got to like work on all fronts at the same time to optimize. And what's interesting is estrogen is so important to the heart and the brain that its own metabolites, like 2-methoxyestradiol, actually have their own receptors in the mitochondria in the heart and the brain to improve energy production. So estradiol is not only directly effective on receptors, it works as what they call estrogen-related receptors. So it has to be there for a different ligand to bind to the receptor. So it's like a cofactor in many functions, and you need the estradiol, and then its own metabolite, 2-methoxyestradiol, actually has its own receptors. I mean, there's just nothing about estradiol that says don't give it. You know, it's like so important. And these are all from estradiol, not from estriol. So I know some people are so wedded to this idea of bias and that it just feels like they can't change, but you can change. That's what makes us the best, because we can change, unlike other doctors who are stuck.
So you don't give anything for 4-hydroxy byproduct?
No, well, I'm doing I start every patient off on the reset, and then I do a lot of, time restricted eating and exercise. We have, a gym in my own office. I mean, so we try to help people to do everything for detoxification while we're working with them. So to get the right nutrients. So micronutrients are essential for all the detoxification pathways. So, you can't like cure leaky gut if you don't have hormones. It's just, people don't realize the gut is completely enmeshed with estrogen receptors. So, you need to have the estradiol, and then you work on all these other factors.
Do you use any calcium diglucarate or DAM or anything?
Yeah, I use them both in like the first month or two. I don't use them chronically, but I do use them in the beginning. Calcium diglucarate blocks, the beta-glucuronidase, but it actually, that enzyme, when properly balanced, is actually beneficial in menopausal women because it actually helps recirculate estradiol. So that's, remember, formulated by people who still think estrogen is evil. So it's actually nature's way of helping to recycle estradiol as well. So so don't think that calcium diglucarate is something that you want to give people forever. It isn't. And the data on it is very weak too.
Okay, we only have a couple more questions in the chat. And accolades. Dr. Jeff Block said thank you. And Dr. Burgess said wonderful. And Kylie asked, cytochrome P systems are necessary to produce progesterone. Is there anything you recommend for patients to support mitochondrial function beyond estradiol therapy? Thank you.
Yeah, periodic fasting will upregulate that enzyme system. And I, in all disclosure, although I haven't done anything in a while, I'm actually on the speaking bureau for L-Nutra, for Prolon, the fasting mimicking diet. But you can do other kinds of, fasting and water fasting if you can get people to do it. But that does upregulate those enzyme systems. That's why fasting increases and improves the whole phase 1 detoxification system. It's like amazing. It's just getting people to do it. I never start with that. That's like advanced lifestyle.
Right. Agree. Okay. What do you do for surveillance for females over 65 who are on estrogen, not covered for mammograms?
What about not covered for mammograms?
Yeah, Nario asked, what do you do for surveillance for females over 65 who are on estrogen, quote, not covered for mammograms, unquote?
Does that mean they don't want to do a mammogram? So I'm not quite sure what that means, but basically, mammography doesn't save a lot of lives. It saves a very small number, but from a medical legal point of view, I think it's a good idea to get mammograms like every other year on patients, it's really legal schmeagle, really.
Not
It's-
covered.
Yeah, if they don't have coverage for mammograms, then I think that they should just probably pay for it,
Right.
like every couple of years, just pay for one screening mammogram. Honestly, I see so many lawsuits about missed breast cancer. The reality is that you're not really saving lives. You're just finding breast cancer. But finding breast cancer on a mammogram doesn't mean you saved a life. You do once in a while, but not very often. Most of the time, you are just, people live longer with breast cancer because we find it earlier, but actual mortality from breast cancer hasn't really changed. That's the crazy thing. But we live in a litigious world, so I recommend that you try. And if they refuse it, then just document that patient, understands that mammography is standard of care and refuses it, and just leave it at that. So that nobody can come back and say, what, you didn't offer it?
Right. Okay. Progesterone cycling is for premenopausal women, correct? At A4M event, either you or someone else described how cycling progesterone is not needed post-menopausal.
Oh, wasn't me at all, because I'm totally for cycling, because that's the way the body works. If you give enough, I don't agree with a lot of other people, just for whatever that's worth. It just is, so, you have to decide what you want to do yourself. I'm just giving my opinion, which I think is based on really good science. But if you want to give an adequate amount of estrogen to actually do something, then you have to give enough to grow the lining of the uterus. It's that simple, you're not going to grow anything. You're not going to repair anything if you don't grow the uterine lining. And if you work really hard to prevent growth by giving continuous progesterone down-regulates estrogen receptors, okay? So you're going to give a very small subtherapeutic dose of estrogen, and then you're going to counter it by giving chronic progesterone, daily progesterone, which down-regulates your estrogen receptor. And then at a certain point, it's like, what are you trying to accomplish here? So I am totally for telling women to embrace their femininity and the way that their bodies are designed to work. And I know that people are so brainwashed because birth control pills are given to try to prevent bleeding. And birth control pills are not the epitome of health. And they're not health pills. They're endocrine disruptor pills. And so don't try to avoid the bleeding. Tell people, that if it's too much, then you'll lower the estrogen. If it's just too much, then you're growing too much and it's not tolerable. But tell people, you know what, you can put up with this. Like some people may say, I really hate brushing my teeth. It's so annoying. It's like, well, do you want like your teeth to fall out or floss or whatever, or go to the dentist? Just do stuff. I have never liked going to the dentist. That's why I bring that up. But I have a very nice dentist. But, it's not a thing I look forward to. So I think it was childhood trauma. But in any case, people do stuff they don't like all the time because it's good for them. So just tell them, you know what, it doesn't matter if you don't like it. You put up with it because it's good for you. Okay. It's a small price to pay for having all the benefits of these hormones. Remember, they're life hormones. They're not sex hormones.
We had a statement in here that during October, there's usually special programs for screening mammograms.
Oh, okay. Then you
Yeah.
should do it every month, or every year on the month that they have the specials.
And I just personally wanted to thank you for all the litigation you're doing. I don't know if you have worked with or listened to Dr. Pam Popper. She's created
No.
Make American Great Again. And it's for litigation for licensed practitioners and non-licensed practitioners, the coaches, consultants, advocates, activists. They're coming after both of us now. And they estimate there's well over 1 million non-licensed practitioners that's getting into this industry. And I just wanted to ask if you had heard about that.
No, but there are many people practicing medicine without a license now.
Right.
Who don't have the credentials, and yet they're doing diagnosis and treatment as if they are legitimate, doctors.
Wow. Yeah. Wow.
So
And then I
I
also,
am, I just think I'm a little bit like old fashioned, stick in the mud, that you should have the credentials to do what you do.
correct. Okay. And then also you mentioned about your grandma. As someone who is specializing in suicide, I understand anonymity. And we are recording this. Would you like me to tell Dr. Clearfield to have that taken out?
No, that's okay. I don't think like 10,000 people. I don't know what you're, well, maybe it will help prevent one suicide.
Amen. I agree. I agree. And you got a lot of accolades, a lot of thank you from everybody.
Well, I
Definitely.
appreciate it. And I know for all of you to delay your dinner for me. Okay. So go enjoy your evening, and we'll get together another time.
Thank you so
Okay.
much.
Thank you
Thank-
very much, Dr. Felice. I'll be bothering you with a text, so asking you to present.
Okay.
All right, take care.
That's fine. Have a good evening. Bye, everybody.
Have a great evening, everybody. Wonderful class. Go ahead.